So hello everybody. So we are going now to talk about progress in treatment of variant histology in RCC. We have very good speakers and very interesting topics. So our first speaker, she's an expert in the field, and is Manuela Smidinger, that she's going to talk about papillary RCC. So Manuela, when you want.
Thank you, and it's a pleasure to be here today, and I would like to thank the organizers for inviting me to this conference. So my part in this session on variants, histologies in kidney cancer is the papillary RCC type. And I'd like to start with a patient of mine who, at the age of 19, in November 2016, was diagnosed with a tumor on his left kidney. He underwent nephrectomy and lymphadenectomy, and the initial diagnosis was that this is a translocation carcinoma. However, 1 year later, the disease recurred. He had fever, night sweats, and abdominal pain. He was then referred to our department, and we insisted on doing another biopsy of this metastasis of this psoas lesion, and it turned out that this is not a translocation, but papillary RCC. At that time, we still classified it into type 1 and type 2, so it was classified type 2. PD-L1 and c-Met were positive on immunohistochemistry. So what are the challenges when selecting treatment for patients with papillary RCC? First of all, it's a change in the classification that has occurred recently, and this was based, as you know, and we have heard a lot about this yesterday, on the fact that molecular studies clearly show that type 2 is not a single tumor entity, but a group of tumors with different molecular background. And now we have the situation that the anyway low number of patients with papillary RCC is further narrowed down by this heterogeneity of papillary RCC and the variety of the underlying molecular driver. Another challenge is that we do have a large amount of basket trials, including all different histologies, and many studies also don't report actually the outcome by histological subtype. More recently, trial designs have moved on actually from basket trial to papillary trial, and more recently even to MET status-driven trials, and I think this is a very important development. So when we look at the studies reporting outcomes by subtype, and have only selected today those studies that really reported on the papillary subtypes, you can see that the numbers of papillary patients in these basket trials actually is really low. What is encouraging when patients are selected based on their histology for trials, if a trial is no longer a basket trial but a specific papillary trial, the numbers increase and people really try to bring patients to these trials. So here we have higher numbers, but in fact the numbers are still low for a trial. Looking at the response rate and outcomes with, from agents that were targeted agents but not involving MET, we have seen response rates of 1 to 39%. Please don't overestimate the green bar with 39%. This was a very small phase 2 trial on pazopanib, including 19 patients with papillary RCC. I mentioned it nevertheless, but you can see, so it's in range of 1 to 39% with VEGF-R TKIs not involving MET or mTOR inhibitors. And on the right side, you can see a trial that was conducted more recently on an EGFR inhibitor combined with a VEGF inhibitor. I'm just addressing here the population of patients with the sporadic papillary RCC, not those which HL-RCC. In this trial, 35% had also spontaneous papillary RCC. Again, as you can see, the numbers in terms of patients are low in these trials. And with respect to progression-free survival in these trials, usually it doesn't exceed 8 to 8.5 months. What else do we have? More recently, we have better studies addressing also the MET status or trials that involved a VEGF-R TKI that had also that addressed also MET, such as cabozantinib, or we do have trials that were purely using agents that were addressing MET. And these agents, in fact, appear to outperform the classical VEGF-R TKIs and mTOR inhibitors when used in a very well-defined patient population. For example, the trial with foretinib, I agree it's a small number of patients again, but when patients had a germline MET mutation, 50% of the patients achieved an objective response. Savolitinib was shown to be superior to sunitinib in a MET-driven patient population. Cabozantinib was shown to be superior to sunitinib in patients with papillary RCC. This was demonstrated in the phase 2 SWOG trial. And again, when you look on the right side on the table for PFS, we do see a signal also with respect to an improvement of PFS with MET targeting agents. Immune checkpoint inhibitors appear reasonably active in this setting of papillary RCC. Results are kind of in line with what we see from single agent. The largest trial is the trial by David McDermott, where 118 patients had papillary subtypes and the response rate was around 29%. We also do have a trial, the CheckMate 920 trial, who had only 18 patients with papillary RCC, also showing a response rate around 30%. And what is less clear actually is the role of nivo-ipi, but this is going to be clarified in the Sunny-Focus trial. What really seems to be a major progress in papillary RCC is when immune checkpoint inhibitors are combined with targeted agents. So this is a similar pattern as in clear cell RCC. The combination appears to outperform single agent. And these are the trials that were conducted. Again, I'm just showing the subgroups of patients with papillary RCC. The trial published by Christina with durvalumab and savolitinib, where 53% of patients had an objective response when they had a MET-driven disease. The cabo-atezo trial ranging between 25 and 47%. The trial conducted by Laurence with lenvatinib pembrolizumab patients, they had 51 patients with papillary RCC, and the response rate was 53% in this subpopulation. And last but not least, a combination of cabozantinib and nivolumab. 32% of patients had papillary RCC, the response rate, again, 57%. Progression-free survival is not reported in most of these trials, and this is, of course, something that we will need to see to really better know what is the true impact of these combinations, but for the moment, in terms of response rate, it looks really promising. So when we summarize the trials reporting outcomes from papillary RCC, by indirect comparison, of course, the best performers are in a MET-driven population, a combination of a MET inhibitor such as savolitinib and durvalumab, or foretinib, but be aware of the very low numbers of patients in that trial. And when we have a MET unknown status, and this is in clinical practice, of course, much more common, then it would be a combination of lenvatinib pembrolizumab or cabo-nivo or cabo-atezo, which all of these combinations have shown a response rate of around 50%. Followed by erlotinib, bevacizumab, axitinib, and TKIs. We have a number of trials ongoing in papillary RCC. You can see compounds that are very well established, such as axitinib and pembrolizumab, but you can also see new compounds such as palbociclib. And we have basket trials. These trials are going to be again, they will again include various histologies, but they are interesting nevertheless if the numbers of different subgroups are big enough. So what are the next steps in this field, actually? We have moved on from basket trials to papillary trials, molecular, target-driven papillary trials, and what could be a next step? And I think conducting trials with papillary RCC only has already been a major step when compared to the basket trials, but given the heterogeneity of this subtype and the different molecular drivers, further big steps are needed, and I strongly believe that we won't identify a single agent that is going to be as our standard of care for papillary RCC. What is probably needed are to make the next big step is screening from patient-derived cell lines and to enable a personalized care in papillary RCC. And here, just as an example, a high-throughput drug screening has revealed from patient-derived cell lines from papillary RCC that the EGFR BCL axis could be an interesting target. Combination of an EGFR inhibitor and BCL-XL inhibitor showed to have a significant tumor reduction in solid tumors. Also, Hitchcock protein 90 inhibitors were shown to be active in this specific disease. And finally, CDK4/6 inhibitors, such as palbociclib, that is under investigation in a papillary trial, was shown to be synergistic, actually, with sunitinib and also with Hitchcock protein 90 inhibitors. So I think there are a number of very interesting compounds. These are only a few that I'm showing that may enrich the field of therapies for papillary RCC. Let me just go back to my patient. How did we proceed? So between January 2018 and December 19, he received nivo-ipi at that time. He had a partial response, lasting, however, only 6 months, and then he had kind of a mixed response, so we decided to add stereotactic radiosurgery, and he remained on nivo maintenance and was then no evidence of disease for 24 months. And when he progressed, we treated him with nivo-cabo. Again, we had a mixed response. We added again stereotactic radiosurgery and brought him back into no evidence of disease status. And Victor wants me to show this picture of him. So it's the guy with the helmet, in the red helmet. Also, his friends agreed to be seen on a big screen on a meeting, and his current survival is 41 months. As I said, he's no evidence of disease, but we need to fight to get the right treatment in the case that something goes wrong. So my take-home message is, in terms of research, more trials are now focusing on papillary, and we need even more of that. Performing non-basket trials has been a major step forward, and I think what is really important, we really should collect all these tumors for biobanking. So it doesn't move on. Can you move on for me? Treatment, regarding treatment, if clinical trials are not available and every treatment is reimbursed, imagine an ideal world, then I would say if MET has been identified as a driver, I would personally use a PD-1 inhibitor and a MET inhibitor. Whether this is a more precise or a broader TKI, it can be decided. If the MET status is unknown, my preference would be cabo-nivo or len-pem. And if combinations are not reimbursed, then cabozantinib, axitinib, sunitinib, pazopanib, all of them have shown some activity, but bear in mind that cabozantinib is superior to sunitinib according to a randomized trial. And also I believe that local treatment remain important, particularly in a disease where we have little, where we have a gap of knowledge. An outlook due to the heterogeneity of this subtype and the small numbers of patients, individual target or drug screening seems a reasonable way to move forward. It's unlikely that we will target papillary RCC with a single agent. Thank you very much.
Okay. The next speaker is Dr. Stefan Udard, and he's going to be talking about chromophobe RCC.
Thank you. So first of all, it's a great pleasure for me to be here today, and I would like to thank you, the IKCSEU committee, to let me speak about chromophobe RCC. So what are the learning objectives? Is to understand the difference between clear cell carcinoma and chromophobe RCC, and to better identify chromophobe RCC at histological and molecular phenotype level, and to know today, or maybe tomorrow, which drug to use or which combination which could be the best regimen for our patient. To introduce chromophobe RCC, first of all, it's the third most common subtype of RCC. It was first described by Tornes in 1985 It accounts for around 5% of RCC cases, and approximately 4,000 new cases in US was reported in 2020. It has a low metastatic potential. It's often curable with surgery alone, and it's more frequent in male than female. It's sometimes associated with Bird or Dubé, tuberous sclerosis complex, or Cohen syndromes. 5 to 10% of patients develop metastases which are mainly liver or lung, and so far today, there is no standard of care for this patient. So what do we know about the histological level on chromophobe RCC? First of all, this tumor is originated from cells of the distal tubule of the nephron. We have two variants, classic and eosinophilic subtype. And as you know, conventional ISUP grading system does not apply for this tumor due to inherent nuclear atypia. Sarcomatoid changes are infrequent and are usually associated with bad outcome. Looking at immunohistochemistry, these tumors are positive for CD117 and CK7, which is done in routine. You may have also loss of RB1 and also low expression or no expression of PDL1. Looking at molecular characteristics, we have aneuploidy with loss of entire copy of chromosome, or a lot of chromosome here, loss of HNF1B increase, inducing chromosomal instability, mutation of P53, P10, and mTOR pathway, alteration of third promoter implicated in oncogenesis, and higher number of copies of mitochondrial DNA. This is the distribution of chromosomal loss and gain in classical and eosinophilic chromophobe RCC. If I just focus on eosinophilic chromophobe RCC in gray, you have only loss of chromosome, whereas for classic chromophobe RCC, you have loss and gain. So further, what is the difference at the cellular and molecular level between clear cell carcinoma and chromophobe RCC? Well, first of all, you have a huge number of aneuploidy and loss of chromosome for this tumor type. You have a low rate of mutation per megabase pair. You have not involvement in VHL pathway. You have mutation at the P53, P10, and also TORS1 and TORS2 level. Looking at mRNA signature, you have an increase in ion transmembrane transport signature. You have also a high expression of gene involved in Krebs cycle. And also, as I said, you have low expression of PDL1 or no expression at all. So now moving to efficacy regarding TKI. This is a summary of all the studies which were performed with either sunitinib, sorafenib, pazopanib, cabozantinib, or axitinib. As you can see, very few number of patients, from 5 to maybe 20 patients. So what we can say so far, the objective response rate range from around 5 to 40%. The median PFS range from 5 months to 1 year at the best. And sometimes we don't have any information regarding OS because, in fact, in this study, it's a mixture of papillary tumors, chromophobe, and so on. So it's difficult to have any endpoint regarding OS. Now, regarding the mutational landscape of chromophobe RCC, this is a nice study taking into account 92 chromophobe RCC tumors enriched with metastatic cases. You can see here on the upper row. And they look at NGS analysis and immunohistochemistry, and it was validated by external cohorts. What we can see, according to stage, metastasis, and type of variant, that we have in quite frequent cases mutation at the P53 level, at the mTOR level, TORS1 and TORS2, and this is confirmed looking at immunohistochemistry, looking at PS6 immunochemistry level. And this results in mTOR pathway mutation, which is present in around 17 to 20%. So now moving to drugs which are involved in this pathway, looking at mTOR inhibitor. This is a study in non-clear cell carcinoma, taking into account either temsirolimus or everolimus. And as you can see here, just focus on 9 chromophobe patients. And as you can see, the best outcome would be either stable disease or progressive disease. Now moving to other study involving mTOR, 3 studies with everolimus and 1 study combined with bevacizumab. Very, very few patients, less than 10. The objective response rate, I don't know if I can share with you the percentage of this objective response rate, ranging from 20 to 40%. And the PFS was around 1 year and quite no data on OS. So what is the expression regarding, the immune system in chromophobe tumors? Well, this is a study about more than 100 patients looking at not clear cell carcinoma. And if I just want to focus on chromophobe, here, looking at PD-L1 expression, PD-L1 in tumor cells membrane is around 5.6%, and tumor infiltrating mononuclear cells is around 36%. So what are the efficacy of those checkpoint inhibitors in this chromophobe subtype tumor? If we look at monotherapy, pembrolizumab or nivolumab and salvage ipilimumab regimens, well, the response rate is quite low, less than 20%. The PFS is quite short as well. And if you look at combination with either with TKI so far, well, it's not so good. And I want to just, to focus on this, study conducted by Thomas Hudson, looking at lenvatinib plus everolimus. We have quite few number of patients that I want to focus on chromophobe here, 9 patients, but the objective response rate was around 44%. And if you focus on median PFS was around 13.1 months. So now moving to ongoing clinical trial. We have many ongoing clinical trials, but no one is specifically focusing on chromophobe. So it's a pool of papillary, chromophobe, and so on. So I'm not sure that we will have, a good answer regarding this specific treatment towards chromophobe RCC tumors. I want to focus on the phase 3 trial here, the STELLAR study, and also the study forecast. But we are waiting for more data and more results regarding those clinical studies. My take-home message today is a surgery for localized disease. It's a gold standard for better RFS and OS as compared to clear cell carcinoma. Larger tumor and sarcotomy differentiation of chromophobe RCC is associated with a metastatic development. We have no standard of care to date. Objective response rate to checkpoint inhibitor is disappointing, maybe due to a lower tumor mutation burden and PD-L1 expression. Enrollment of patients into clinical trial is mandatory, and specifically regarding study which focus on chromophobe. And emerging data from the genomic landscape of chromophobe RCC may provide new insight into druggable target for this patient. And I would like to thank you for your attention.
Thanks for the great presentation. So our next speaker is Giuseppe Procopio from Italy, and I'm sure he is going to shed some light about collecting that and renal medullary carcinoma.
Thank you, Chris, and I will thank the organizer for giving me the opportunity to talk about collecting and renal medullary carcinoma. And during my presentation, I will put your attention on these major points. Are collecting and renal medullary carcinoma the same disease? How to treat advanced cases unsuitable to receive a local-regional treatment? And may we translate some information from bench to bedside? In 2016, WHO classification considered that both histotypes are part of clear cell renal tumors. But the 2022 edition of WHO classification considered mandatory to involve renal medullary carcinoma in the molecularly defined section due to the SMARC CB1 deficiency. The histological diagnosis of both tumors often is not so easy, but there are some molecular alterations that permits to identify several genomic hallmarks. Unfortunately, the lack of biomarkers or predictive signature do not permit to define well the current standard treatment for advanced disease. So look inside at both tumors. Collecting data is more frequent in male, elderly, arising from the distal part of collecting data, and more than half of the patient had advanced disease at diagnosis. And some genomic alterations were identified. The majority are somatic mutations, and in preference located in NF2, SET2, and SMARCB1 genes. And collecting data could be also considered like a metabolic disease due to a pathognomonic signature, having immunogenic and metabolic alterations. Renal medullary carcinoma involve a completely different population, younger, African, associated with sickle cell trait. More than 80% of the patients had advanced disease at diagnosis and very, very poor survival. The molecular profile is completely different from other renal cell carcinoma due to the high number of focal chromosomal alterations and the loss of SMARCB1 gene, a potent tumor suppressor gene located on chromosome 22. And in this type of very rare tumors, we have an upregulation of several genes associated with replication stress and innate immune response, upregulation of hypoxia-inducible factors and knock path, and the downregulation of several metabolic pathways, and a very particular immune profile. What clinical data in both tumors? In renal medullary carcinoma, only few retrospective series, suggesting that platinum-based chemotherapy could be considered an option, of course. In collecting that, we have some prospective data. The most important was an historical trial led by Stefan using platinum-based chemotherapy, reported 26% of objective response rate. And this was one of the most important opportunities for this type of patient. Unfortunately, the addition of a multikinase inhibitor like sorafenib or a VEGF inhibitor like bevacizumab did not add efficacy. So triplet therapy did not demonstrate any additional benefit in comparison with platinum-based chemotherapy. And what about multikinase inhibitor alone? We have some retrospective data using old multikinase inhibitors like sunitinib and sorafenib, demonstrated some degree of activity in terms of tumor shrinkage. Unfortunately, remains very, very poor survival and very, very poor efficacy in terms of tumor reduction. And recently, the Bonsai trial permits to raise the bar of objective response rate, reported in 35% of the patient in frontline collecting duct disease using cabozantinib. But unfortunately, the survival remains very, very poor. So I would now to put your attention to two short clinical cases. The first one is a female having 77 years. He had a diagnosis of bone mets due to collecting duct disease. She received 2 lines of therapy, cabozantinib followed by nivolumab, and obtained a survival of 3 years. And in this image, you can see the positive effect of cabozantinib on bone mets reported very early in the first month of cabozantinib therapy. And this is a second clinical case. Is a male having 70 years, had lymph node mets at diagnosis due to collecting that, and he received platinum-based chemotherapy followed by cabozantinib. Unfortunately, patient early progressive, early died. So, I think we have two completely different cases with a natural history completely different. The first one more similar to clear cells. The second one a very natural history of undifferentiated tumor of very, very poor prognosis, probably irrespective of the treatment used. So I will try now to look inside the biology of a patient responding, of a patient early progressive. In the bonsai trial, we try to analyze the genomic and the transcriptomic, and we try to compare patient responding with a patient early progressive. And we found that an upregulation of several genes associated with angiogenesis and T-cell immunity in patient responding to cabo, in comparison with a patient early progressive that showed a completely different path. Several somatic mutations were detected, but unfortunately the majority are missense mutation and truncating. And we found also a high tumoral mutational burden in patient early progressive in comparison with patient having a good response. And the majority of the mutation in patient early progressive involved NF2 and TP53 genes, but are pathogenic mutations. So the next challenge will be to try to define a treatment according to the tumor signature. So we have planned this clinical trial, prospective clinical trial. First of all, we collect tumoral tissue and define genomic and transcriptomic, and then we try to define a treatment according to the signature. And we identify 3 groups of potential therapy. Patient having an angio signature that's receiving multi-kinase inhibitors plus a PD-1 inhibitor, in preference cabo plus nivo. Patient having an immunosignature that receive a double IO combo, nivo plus ipi, and the patient without signature that receive chemotherapy platinum based according to the clinical trial led by Stéphane Houdard. Other clinical trials are ongoing, and the majority test a multi-kinase inhibitor like cabozantinib or in association with a PD-1 inhibitor like nivolumab. But unfortunately, these studies are not designed specifically for this type of tumors, but involve also collecting data and the renal medullary carcinoma in a general population of non-clear cells renal cell carcinoma. My conclusions. Collecting data in the renal medullary carcinoma remains 2 distinct entities without a standard of care after failure of a locoregional treatment. Of course, chemotherapy has a role and could be considered as an important therapeutic choice for this type of patient. Targeted therapies are a therapeutic option, more specifically cabozantinib, of course. But we have to consider the use of other new agents. We have to perform investigation to assess the role of other agents. For example, IO combo, but probably other agents could merit to be investigated. ADC, like sacituzumab or enfortumab, PARP inhibitors, or CDK. And please consider when possible to involve this type of patient in a clinical trial. And I would thank the team of NCI Milan. Thank you very much for your attention.
So thank you, Dr. Procopio. And the last talk in this session will be given by Nizar Tanir, who will be talking about HL-RCC and translocation RCC. I guess we'll call it fumarate hydratase deficient RCC and translocation RCC. And Dr. Tanir, take it away.
Thank you, Dr. Atkins. Thank you, Dr. Suarez. And I would like to also echo my colleagues here to thank the organizing committee for the kind invitation to speak about these 2 rare tumors. And these are my learning objectives. Review available literature on therapy of translocation RCC and HL-RCC, counseling patients, and future directions for improved patient outcomes. Because of time constraints, I will not be discussing the complex biology of translocation RCC. Translocation RCC is the most common RCC type in children and young adults. Histology often mimics that of other RCC types, such as clear cell and papillary. And about 20% of patients have a history of chemotherapy exposure for childhood malignancies. Histologic and clinical heterogeneity could be explained by fusion partners. The diagnosis is often suggested or suspected by a positive TFE3 stain, which has nuclear expression, but the gold standard for diagnosis is performing FISH, with the caveat that there are limitations with FISH, and in those cases where FISH is not helpful, RNA sequencing is helpful in identifying fusion partners. There are many subtypes, which I will not go through in this short presentation, but TFE3 translocation is more common than TFEB translocation. TFEB translocation has better prognosis than TFE3 translocation. And TFEB amplification without translocation is more common in older people as well, and is more aggressive than TFEB translocation. I mean, let's look now at what has been published already in this space. And so this is a work that was a collaboration between our institution and the Farber, and we published this more than a decade ago with the first generation VEGF-RTKI. This was a 15-patient retrospective study treated with sunitinib or sorafenib or anti-VEGF. 5 of these 15 patients were confirmed by FISH, and the others suspected or suggested by TFE3 positive IHC stain. There were 3 responders with a median PFS of 7 months and median OS 14 months. Please remember those numbers as we come to a more contemporary data. And here is a little bit more details about these 3 responders. 1 responded to sunitinib, 1 to sorafenib, 1 to an anti-VEGF antibody. The duration of response in the 3 patients was 7, 13, and 27 months respectively. 7 patients of the 15 achieved stable disease, 4 of whom had some tumor regression ranging from 9% to 24%. Now, what about other therapeutic options? And here are the mTOR inhibitors. There is a rationale for using an mTOR inhibitor in translocation RCC based on the TFE3, PI3 kinase AKT-mTOR pathway is active in TFE3 translocation. And the retrospective data is from a publication from the French group by Dr. Gabriel Malouf and his colleagues back in 2010. 4 patients received temsirolimus, 3 received everolimus, and 1 of those 7 patients had a partial response for a 14% ORR, and 6 out of 7 had stable disease with a median PFS, again, modest 3 months. Here are the Kaplan-Meier curves for first-line TKI. Again, the median PFS is really very modest, 3 months with first-line TKI. And then now using an anti-PD-1 antibody, majority of these patients in this publication, again, a collaboration between the French and the USA. We published 5 years ago in JITC. Nivolumab was the most commonly used anti-PD-1 here, and the response rate was 16%. But again, to call your attention to the median PFS of only 2.5 months. So moving forward now, we published last year, and this was presented by Jonathan Touvenat at ASCO, the retrospective study. This is the largest study using cabozantinib. 52 patients were included in that study. Again, not all of those patients had confirmation by FISH. Response rate was 17%. The vast majority of these responses were partial, and there was about half the patients had clinical benefit. And you can see here on the slide the Kaplan-Meier curves for PFS and OS. Some improvement from what we saw previously. The PFS median here with cabozantinib was 6.8 months, and the median OS was 18 months. Now, what about the combinations of immune checkpoint inhibitors and IO or IO and VEGF directed therapies? This is a study we published last year. It was all these 29 patients were confirmed by FISH to have translocation. 18 of those patients were treated with nivo-ipi, and 11 were IO-VEGFR. And as you can see here, numerically, the cohort that was treated with VEGFR, RTKI, and IO had 4 out of those 11 responded for a 36% ORR, versus 1 out of 18 with nivo-ipi for 5.5% response rate. But at the bottom of the slide here is the telling, the median OS was really very, very similar, 13 to 14 months median OS for these 2 cohorts, suggesting that we really have not, if you recall my earlier slides, we have not really made significant progress, unfortunately, in the management of this disease. What about, trials here, prospective studies? So this was a children's oncology group study that was designed and launched by the COG. Unfortunately, the study was recently closed to accrual because of poor patient accrual. Initially, this was a 3-arm study of the combination of Axi and Nivo versus monotherapy of Axi and Nivo. Then they dropped the Axi arm. It was a 2-arm, 1-to-1, Axi Nivo versus Nivo. They had an ambitious enrollment of 87 patients on the 3-arm study initially, and then 40 patients on the 2-arm study. But then again, as I said, the trial was closed due to poor patient accrual. Now, shifting gears to HLRCC, this is a rare familial disorder characterized by germinal loss of function alteration in the fumarate hydratase gene, which is a critical TCA enzyme. And then these tumors are characterized by a SIMP phenotype associated with metabolic deregulation. This disease predisposes individual to early onset solitary and aggressive RCC. It resembles sporadic type 2 papillary RCC and CDC, and it used to be lumped together with papillary high-grade RCC, but it's known now as a distinct entity. And many of these patients have cutaneous leiomyoma, as you see here on the slide, and frequently many women have uterine leiomyomas that result in hysterectomies in some of these women. Now, what's the rationale of the biology we know about this? Loss of fumarate hydratase leads to disruption of the TCA cycle and dependence on aerobic glycolysis, which we know is the Warburg effect that really meets the cellular energy demands of the cell. Fumarate accumulation as a consequence of fumarate hydratase inactivation leads to inhibition of HIF proline hydroxylases and increased levels of HIF. Increased HIF levels leads to a transcriptional upregulation of many cancer-relevant genes that we know, including VEGF and EGFR. And based on this rationale, a phase 2 study was conducted at the NCI by Ram Srinivasan and his colleagues using bevacizumab and erlotinib for these individuals. They had the 2 cohorts. This is the study design. The top one in yellow is the HLRCC, 43 patients. The bottom one is the sporadic papillary group. And the treatment was bevacizumab and erlotinib, shown with the dose and schedules, as well as erlotinib on the slide. And what about efficacy? 31 of the 43 patients treated with this regimen had a response. So 72.1% of the HLRCC group responded, and the sporadic was a lower ORR of 35%. And here is a swimmer's plot of the responders. The top in red are the patients who had HLRCC. Median time to response, 1.8 months. Median duration of response, 19.3 months for HLRCC. Now, what about the PFS? Again, here you see the 2 curves for the 2 cohorts. The red to the right is the cohort of patients with HLRCC, and the median PFS is impressive at 21.1 months, a shorter median PFS with the sporadic papillary group. There was a recent study published in CCR looking retrospectively and analyzing 26 patients with FH deficient RCC, where they showed that VEGF monotherapy was associated with an ORR of 20% and checkpoint inhibitors, no responders. This is another study published recently from Korea in 10 patients, a small case series of 10 patients with HLRCC treated with the same regimen of bev-erlotinib with 50% ORR and median PFS of 13.3. But again, the OS was very close to the PFS of 14 months respectively. What about phase 2 trials? So this is the only trial that, again, this was a basket trial published by the Memorial Group last year using cabozantinib and nivolumab in in non-clear cell. Among those 47 patients, 5 had HL-RCC, and the responses are shown here. All 5 patients with HL-RCC treated with nivo-cabo responded, and the tumor regression in these patients ranges from 33% to 100%. So 1 CR and 4 PRs. And you can see at the bottom of the slides the duration of or time on therapy with nivolumab and cabozantinib, about 2 years. And so, but again, this is a small number of patients. At MD Anderson, we treated 2 patients with this regimen who had HL-RCC, and as they say, a picture is worth 1,000 words. This is the 2 patients who were previously treated with bevacizumab and erlotinib and progressed after 6 months. We treated them with cabo-nivo, and this is one of the patients who continues to have really a gratifying response with nivo-cabo 10 months after initiation, and you can see here the PET scan. So take-home messages for translocation. The prognosis of adult patients with metastatic translocation RCC has not appreciably improved over the past decade. VEGF-RTKI, mTOR inhibitors, and immune checkpoint inhibitors as monotherapy as well as combinations, as you saw, have had modest activity. In my opinion, it's only by dissecting the heterogeneity, biological heterogeneity of translocation RCC, will be able to make inroads in management of these patients through discovery of relevant, actionable targets for each of these subtypes of translocation. And for HL-RCC, I think it's fair to say that bevacizumab plus erlotinib yields a 72%, it's an impressive objective response rate, and a median PFS of 21 months in HL-RCC. But again, this is 43 patients. I understand, talking to my colleague, Dr. Srinivasan, this paper now is under review at one of the journals, so hopefully there will be a subsequent trial. They do have plans to launch a trial using an anti-PD-L1 plus bevacizumab erlotinib as the sequel trial to this one. The combination of nivolumab and cabozantinib appears to be effective against HRCC, but only a handful of patients, as I showed you. But it was nonetheless a good signal, especially that these patients, some of them were previously treated with bevacizumab and erlotinib and responded to nivo-cabo. So I think this is an important signal to move forward with this combination in future trials for validation of this as a salvage therapy. But again, as with translocation, only by a deep dive into the biology of this HLRCC and trying to really decipher the molecular alterations, collaborating with fumarate hydratase, we will make inroads into understanding the biology of HLRCC and advance the field and improve the outcomes of our patients. And I'd like to thank you for your attention and thank you for the invitation.
So thanks to our speakers for those complex, thorough presentations. We have time for questions. And please come up to the microphone. Dr. Stieler.
What we see is that with those super rare types, we do whatever we want to do, and it doesn't really seem to work. I mean, if you look in collecting duct, no matter what we do, the overall survival is 10 months. I mean, there might be some response with the one or other regimen. And I think we struggle a lot with the small numbers that we have. So maybe as a call to action to everyone, and some of the junior faculty, or Danny, where is he? Don't see him. We should have an international database where we collect the data. Whatever we do, we should just report it somewhere so that we learn from it. Like cabo-nivo, that seems promising. I'm pretty sure there are more people who tried it, maybe in first line or whatever. I think we really need to gather these information and get better information, what might work and what might not work, because it's totally all over the map.
That's a great point. I'm going to ask, while Laurence is coming up to the microphone, a question for the panelists. Manuela, do we know how many people who are classified phenotypically as papillary are actually VHL null or VHL driven tumors masquerading as papillary?
No, so of course we completely rely on what the pathologist tells us, and at the end of the day, I mean, we are lucky we have a quite good famous uropathologist, Eva Compera, and I really rely very much on her results, but nevertheless, I agree. Treating these patients means you are completely in the hand of the pathologist at the end of the day, but then the treatment today might not be too different. So if I give a Carbonivo as a first-line treatment for a papillary, if it's a clear cell or vice versa, it wouldn't be a big damage. Could only change the course.
Right, but there's all those people, maybe the people who are responding are not truly papillary, and therefore we're assuming the papillary treatment, the treatment works for papillary when if we actually molecularly defined it, the answer would be no.
Well, I mean, this is something that the pathologist in the room might need to answer, probably.
Okay, all right.
We have one.
Yes.
Payal Kapoor from
answer?
UT South.
So Laurence, or
Go ahead.
does the pathology want to answer?
Yeah, there is definitely a missed call. I was going to, I mean, it depends on the experience of the pathologist. So if you are a general pathologist, not seeing too many kidney cancers, the number of entities has increased so much, and the amount of knowledge you really need to keep up with is large, and probably doing that for every organ is challenging. So I think cases that are not straightforward, it is better for somebody who sees these more every day would be able to address in a better subclassification. So I would definitely think of, if it's not making sense, get a second opinion. But Eva's great, so I would trust her. I had a comment on CDC. The comment is that CDC is a vanishing entity. We used to make this diagnosis more previously when FH deficient RCC was not, as well recognized. Now we found that at least, half of the cases that we originally used to think is CDC end up being FH deficient, and others seem better classified as RCC NOS. So just wanted to bring that out before we get into so many drug trials, and you have a mixed bag. You will end up with a very mixed result.
Laurence?
Thank you.
Yeah, thank you. Great session, and thank you for helping us, because this tumor type takes a lot of our tumor board energy to know how to manage them. My question is to Nizar. What is your recommendation in terms of, do we only need to ask for immunohistochemistry staining for TFE3, or do we need to ask for FISH in any young patient with both papillary and clear cell features? What is your recommendation?
Fish, definitely.
So all your patient has a FISH, and is it an age threshold, or is it based on the pattern of
No,
the
I
spike?
think, while, as I mentioned, translocation is more common in children and young adults, but you can see it in older age groups. So I really think any patient that suspected to have translocation, or we call it better MIT family tumor, I think a FISH is important. I mean, again, 10, 15 years ago, we didn't do FISH routinely, but I think now all academic centers are doing FISH routinely on these suspected cases.
Would there be any below 40, 45? How do you decide?
No, I think even, I mean, if the patient has a tumor that has features of papillary, features of clear cell, TFE3 is positive in the stain, then I think that patient should get a FISH for confirmation at any age, because there are patients who are in their 50s and 60s who have translocation as well. I'd like to echo Dr. Kapoor's comment. There is a divide across the Atlantic when it comes to the CDC diagnosis. European pathologists are more liberal in reporting CDC or Bellini's tumor, whereas in the States, at least at academic centers that, I'm the Anderson, I work at UT Southwestern, we are very, very, very rarely are calling CDC. And it's, they call it, possibly CDC, but, it could be unclassified, it could be papillary, so it's really, there is no specific diagnosis for CDC, like for example, FH deficient RCC, you do the FH state, it's negative, that's it, there is FH loss, it's FH RCC, deficient RCC. RMC is easy to diagnose, a patient who has sickle cell trait, SMARCB1 or INU1 loss, that's it, this is RMC. But CDC, I don't think we can be confident saying this is a CDC because there is really no constellation, aggregate of clinical as well as molecular or genomic specific for CDC to really be confident to say this is definitely CDC. I agree with Payal.
I have one question for Stefan. So, what's your favorite treatment in chromosome in the presence of mTOR alterations, or in the absence of molecular testing? So, in both situations, would you use? Because I have very good experience using mTOR inhibitors in these patients. So, would you consider an mTOR inhibitor, especially based on the poor results with IO and TKIs?
In the presence of mTOR mutation, of course, I would go for mTOR inhibitor.
In both situations, if you have an mTOR alteration and in the mTOR pathway, and if you in the absence of molecular testing.
Okay, so in absence of mTOR pathway, I think it's difficult. So I don't have the answer so far. So maybe to go for TKI, but as I showed, the VHL, pathway is not involved. So maybe we need to look at other pathway. And we had a wonderful talk yesterday, and maybe cysteine pathway. We're looking at metabolism, target so far, but we don't have so far drugs, and very very few drugs, and maybe the industry need to put money and to be involved in this rare tumor to put, to build clinical trial to be smarter.
Thank you. I think we have time for one last question.
Yeah, thank you. I have a question to Dr. Udar and Dr. Procopio. So, Dr. Udar, you conducted the first phase 2 trial in collecting duct using chemotherapy. Dr. Procopio, you have done also the first using cabozantinib. Can you tell us, Dr. Procopio, if you will do chemotherapy as first-line setting in patients with collecting duct? And Dr. Udar, what would you do? You would do cabozantinib or not? Thank you.
Start. You can start.
In my opinion, chemotherapy remains the first choice to be considered in collecting duct disease because there are more data, more clinical data, because collecting duct is more similar to urothelial carcinoma. So for several patients, I think, first of all, we have to consider chemotherapy with platinum-based. But the best choice remains a clinical trial, of course, when possible.
Yes, thank you for the question. So we performed 2 prospective clinical trials in Bellini tumors, even though, the definition is quite difficult to have. So it's quite, tough because, as you know, it's 1% of kidney cancers. So to perform a clinical trial, it's tough. And I saw that you have a clinical trial in Bellini tumors with 3 arms, randomized, 3 different choices. It would be difficult to my mind, but anyway, I think we should go further. The first trial we performed was to look at chemotherapy, and the second one was to add the bevacizumab to chemotherapy. Hopefully, the paper was accepted a few days ago, and we published in the European Journal of Cancer. And at the end, we had some toxicity regarding the association, which impact on the outcome of this study. I had the feeling that by adding bevacizumab was some really useful for some patients who had a very long-lasting, disease and who are still alive. But nevertheless, you need to, of course, to take into account toxicity. I think if we shouldn't go further, so I was thinking yesterday, why not, to put, all these drugs together, chemotherapy and cabozantinib in first line, just to have the best, treatment strategy to have the greatest objective response rate, or maybe complete response as well. I don't know. So far, we don't have so many targets to go for. So we will see. I think the combination would be maybe too toxic for the patient because we have some toxicity with bevacizumab. So we need to, I don't know, maybe we We need to have young people to be smarter and to, but I think the recommendation is to put those patients into new clinical trial, otherwise, it's a waste of time for clinician and patient.
So just wanted to, if I may, Dr.
Nizar,
Atkins.
I think we're out of time. There's another session. I think we have to end and thank our speakers. And if other people have other questions, you can come up and ask the speakers during this break. But thank you all.